It's been a long, long time that patients who have operable non-small cell lung cancer have not really had much more than conventional chemotherapy to support better long-term outcomes. We know that recurrence originating from micrometastatic disease at the time of surgery is an all too common occurrence for this population, so there was a huge unmet need. And CheckMate 816 is actually the first study to report the addition of immunotherapy in the pre-operative window to support the systemic effort to reduce distant disease. So a very important study for a growing population of patients. CheckMate 816 is a phase 3 randomized controlled trial, open label, comparing conventional cisplatin doublet chemotherapy to chemotherapy plus Nivolumab for 3 cycles prior to surgery for patients with operable stage 1B to 3A by the old HACC 7 staging classification. Surgery had to be lobectomy, bilobectomy, extended lobectomy, or pneumo-nectomy, and there was no adjuvant immunotherapy, although patients could receive either additional chemotherapy or adjuvant radiation based on physician tumor board patient consensus. And we now have the results of the independent primary endpoint of pathological complete response, which was reported by Dr. Patrick Ford back in the spring at AACR. And here we're reporting the exploratory surgical feasibility and safety outcomes accompanying those results. So as I said, the pathological complete response rate was dramatically higher in patients who received chemoimmunotherapy before surgery, indicating a far more efficacious treatment regimen from a biological standpoint. There's a little more than 12-fold increase in the rate of pathological complete response, meaning no residual tumor cells in the tumor bed or lymph nodes by blinded independent review. And this was on an intent to treat basis. So on its own, an extraordinarily important finding, showing that we have a highly active regimen in this space. Of course, if that was accompanied with a higher surgical risk or worse perioperative outcomes, this would have been a serious problem. So I think that speaks to the importance of the results we're presenting now, where we see that patients who received the chemoimmunotherapy prior to surgery actually had a lower rate of requiring pneumo-nectomy, higher rate of complete resection with no adverse event signal. In fact, quite the contrary. It seems that the operations may have been easier with a shorter operative time in the patients who received chemoimmunotherapy prior to surgery. And as I said, no adverse event signal in the postoperative period. So very compelling results that we have a highly biologically active regimen that doesn't confer any additional risk, if not perhaps some benefits. So although the FDA hasn't yet approved pathological complete response as a surrogate endpoint for survival in lung cancer, it's an improved metric for breast cancer. I think that's going to come. CheckMate 816 is also powered for event-free survival. So as those data mature, I'm confident that this will be positive. As I mentioned, patients in the treatment arm, chemotherapy plus Nivolumab, had fewer pneumonectomies, quite a bit fewer pneumonectomies. We know that the 90-day mortality from pneumonectomy is 2 to 3 times higher than patients who have lobectomy. So on its own, I think early event-free survival promises to be positive, but we'll see. But even without an OS signal, the fact that you have a highly active regimen that allows for safer, less impactful, less lung resection being required, less high-risk lung resection being required, I believe is an extraordinarily important endpoint, one that's not yet recognized by regulatory agencies, but we're talking about the lung, which is a vital organ and contributes significantly to people's quality of life and morbidity profiles. So I believe that the combination of the pathological complete response rate with this very encouraging surgical safety set of findings promises to sort of change the way we think about approvals of new regimens for lung cancer patients. I think it's important to recognize that this is just the first wave of immunotherapy-based regimens in the preoperative window. So there's, although I guess you could say only saw 25% pathological complete response rate, there's an enormous opportunity to improve upon that with various combinations, be it by changing dosage schedule, regimens, frequency, and bringing in other novel agents. So I think the next few years we'll see higher and higher levels of pathological complete response rate. And so it'll be necessary for us to be able to predict that in a non-invasive fashion so that we can tailor future trials to decide whether local therapy is even necessary in some patients or not. So very exciting times for lung cancer patients, a lot of opportunities to improve their care, not just on overall survival, but on the entire experience of the treatment trajectory, which I think is extremely important.